Imagine taking a high-powered medical laser, the exact kind used to precisely vaporize layers of skin on your face,
Sure.
and just applying it entirely blind, deep inside the human body.
Right. Relying on this, like, mass-produced, one-size-fits-all plastic tube.
Exactly. I mean, when you picture a medical procedure, you probably picture absolute measurable precision, Like an x-ray shows a broken bone, the surgeon uses customized plates to fix it, the geometry is perfectly understood.
Yeah, it's mapped out. But today, we're looking at the frontier of vaginal health, where that cutting-edge technology is violently clashing with the unpredictable, deeply variable reality of human anatomy.
It's wild. Whether you are catching up on medical tech or just insanely curious about how the human body works, you are in the right place. Our mission on this deep dive is to synthesize a massive stack of clinical trials, FDA safety communications, and anatomical case studies to understand this booming yet fiercely controversial medical field.
It really is a profound shift in gynecological care. It perfectly illustrates that tension between engineering and biology, I think. We're taking energy-based devices, technologies rooted in dermatology, and deploying them in an internal environment that is basically the absolute definition of diagnostic muddy waters.
Right. Okay, let's unpack this.
Mhm.
Because we are exploring the use of energy-based devices, or EBDs, to treat severe menopausal symptoms. And the central tension we are going to explore today is how complex, altered human anatomy, specifically something called a modified vaginal cuff, completely breaks the design of standard medical probes.
Yeah, and before we can understand the controversy or that anatomical mismatch, we really need to understand what these devices are actually doing at a microscopic level.
Right, what's happening to the tissue?
Exactly. So our clinical sources detail three main types of energy-based devices. First, we have CO2 lasers. These are microablative.
Microablative, meaning they destroy tiny bits of tissue.
Yeah, they use specific pulse modes to literally vaporize water in the tissue. This creates thousands of microscopic thermal channels. Essentially, they're inflicting tiny, highly controlled wounds into the surface layer of the tissue and the layer just beneath it.
Okay, so the sources mention the epithelium and the lamina propria. So we're talking about vaporizing tiny holes through the protective surface layer, the epithelium down into the deeper structural connective tissue.
That is the exact anatomical target.
Got it.
Then the second type is the ERYAG laser. This one operates a bit differently because it uses a specific wavelength of 2940 nanometers. In physics, that specific wavelength has an incredibly high affinity for water absorption.
So it's drawn to water.
Right. So instead of instantly vaporizing the tissue like the CO2 laser, the water inside the cells absorbs the light, producing this gradual controlled heating. It remodels the tissue without necessarily destroying the surface layer.
Oh, interesting. And the third type.
The third is radiofrequency, or RF, devices. These abandon light completely, just use focused electromagnetic waves.
Okay, so electromagnetic waves pass into the body, and the tissue itself acts as a barrier, right? Creating resistance or impedance.
Exactly, yes.
And that physical resistance generates heat from the inside out, deep within the connective tissue. It reminds me of how an incandescent light bulb filament glows and heats up because it's resisting the electrical current passing through it.
That's a great analogy. And, what's fascinating here is that despite using completely different mechanisms like light ablation, water absorption, or electromagnetic resistance, they all rely on the exact same underlying biological principle.
The photothermal effect.
Right. By inducing a very specific, controlled thermal stress in those deeper collagen-rich layers of the vaginal wall, the body is tricked into initiating a massive healing response. The heat stimulates fibroblasts, which are basically the biological factories that build our tissue's structural framework.
They kick into overdrive, triggering neocollagenesis, so building brand new collagen and elastogenesis, spinning out new elastin fibers.
Exactly. It's entirely reliant on hijacking the body's own wound healing cascade.
So this is basically like aerating a lawn. When soil gets compacted and the grass dies, you don't just paint it green. You intentionally punch thousands of tiny controlled holes into the dirt. That minor injury forces the root system to panic, adapt, and grow back exponentially thicker and healthier.
That microscopic cellular response is exactly why these therapies are being used. They're non-hormonal second-line treatments for conditions like genitourinary syndrome of menopause, or GSM, stress urinary incontinence, and vulvovaginal atrophy.
Which are huge issues.
Yeah. When a woman's estrogen levels drop during menopause, the vaginal tissue physically changes. It thins out, loses elasticity, and the blood supply diminishes dramatically.
Which translates into severe daily quality of life issues. We are talking about chronic dryness, severe pain during intercourse, urinary leakage.
Yeah, it's debilitating for many. But when researchers in our sources biopsied and examined the tissue after these laser or RF treatments, the transformation was undeniable. By forcing the tissue to rebuild, it physically reversed the signs of atrophy.
Wow.
The treated mucosa becomes well-nourished. Under a microscope, they observed extended three-dimensional papillae-rich blood vessels, meaning the intricate network of blood flow was fully restored.
That's incredible. The tissue itself became thicker too, right? And they measured a significant increase in glycogen and lactobacilli.
Yes.
With glycogen being the stored cellular sugar that feeds lactobacilli, the good bacteria required to maintain a healthy, acidic environment to prevent infections. So the laser forces the tissue to rebuild its own defense mechanisms.
It does. But, aerating a flat two-dimensional lung is a beautifully simple process. Applying that intense, precise thermal energy inside a dynamic, highly variable three-dimensional human body, that presents an enormous physical challenge.
Right, because the body isn't a flat lawn.
Exactly.
Yeah.
This is where the engineering of the device violently collides with the biological reality of the patient.
Yeah.
And it centers almost entirely around a structure called the vaginal cuff.
Okay, so let's define that. When a patient undergoes a total or radical hysterectomy, the cervix, the lowest part of the uterus that connects to the vaginal canal, is removed. To close off the pelvic cavity, the surgeon physically stitches the upper portion of the vaginal canal together.
Yes, and that surgical seam at the very top of the vagina is the vaginal cuff.
Got it. So how did these devices interface with that?
Well, the standard treatment protocol for these energy-based devices dictates the use of rigid cylindrical probes. The manufacturers provide these perfectly straight wands, often made of plastic or metal.
Okay.
Some fire the laser at a 90-degree angle, some fire in a full 360-degree pattern. The practitioner is trained to gently insert this rigid cylinder all the way to the top of the vaginal canal until it meets the vault or the cuff. They fire the laser, carefully withdraw the probe exactly 0.5 centimeter, rotate it slightly like the hands on a clock, and fire again.
So they are using the etched markings on the probe to map out a 360-degree grid of laser fire as they pull it out.
Exactly. Attempting to ensure complete coverage from the surgical scene at the top all the way down to the opening.
But this reveals a terrifying flaw in the geometry. If the probe is a rigid cylinder, but the patient's anatomy is irregularly shaped or scarred at the top, doesn't that mean the laser is either missing the tissue entirely or pressing way too hard into it?
Yes. That internal geometry is no longer a perfect tube. Add in the variables of severe atrophy or perhaps fibrotic scar tissue from previous pelvic radiation.
Right.
The vaginal apex might be drastically narrowed, entirely asymmetrical, or incredibly fragile. Our sources explicitly note cases of severe stenosis where patients couldn't even tolerate the initial insertion of these standard probes.
Man, it's like trying to perfectly paint the inside of a crumpled paper bag using a rigid, straight paint roller. If you just shove the roller in and spin it, you're going to completely miss the deep crevices where the roller just hovers in empty space.
Yeah.
And you're going to press dangerously hard against the folds that protrude inward.
In physics and medicine, we call that suboptimal dosimetry. The rigid probe fails to make uniform contact, so the energy distribution is chaotic. It undertreats the gaps and catastrophically overtreats the pressure points.
Wow.
And the greatest risk highlighted across multiple surgical sources in our stack is what happens when that excessive thermal energy is deposited near the vaginal cuff.
Because that surgical seam is already compromised tissue.
Precisely. Applying intense heat and physical pressure to a healing, previously irradiated or severely thinned out vaginal cuff carries the severe risk of cuff dehiscence.
Cuff dehiscence. That is a horrifying scenario where the surgical closure actually tears open, right?
Yes. The sutured closure fails entirely, opening the pelvic cavity. It is a severe medical emergency requiring immediate surgical intervention. The sources explicitly list radiation, vaginal atrophy, and excessive electrosurgical energy as major compounding risk factors for poor wound healing and dehiscence.
And a standard rigid probe just cannot adapt to those anatomical peaks and valleys.
No, I can't.
So what does this all mean? We have this severe risk of burns and scarring, which makes perfect sense why this anatomical mismatch fueled an absolute firestorm of controversy. It's heavily divided the medical community.
It has.
Let's look at the regulatory side of this clash impartially. In 2018, the FDA issued a severe safety communication. They explicitly warned against using energy-based devices for vaginal rejuvenation or for treating symptoms of menopause, urinary incontinence, or sexual function.
And the FDA's concern was entirely data-driven, rooted in reports submitted to the MED database, their adverse event reporting system. They cited cases of severe vaginal burns, deep scarring, fistulas, which are abnormal holes forming between organs, and chronic recurring pain.
Yeah, there is a case study in our stack that perfectly illustrates the danger of that anatomical mismatch and uncontrolled thermal damage. A 48-year-old woman was receiving ARO-YEG laser treatment for stress urinary incontinence. After her second session, she experienced extreme pelvic pain. When doctors examined her a few months later, her body's wound-healing response had gone into severe overdrive. She had developed a complete transverse vaginal septum. Her body literally built a solid wall of scar tissue across the canal, shortening her functional vaginal depth to just 2 to 3 centimeters. The upper vault and cervix were completely sealed off and invisible.
It is a devastating complication. The thermal energy caused catastrophic inflammation, and the body basically fused the damaged walls together in a desperate attempt to heal.
But the FDA's regulatory caution was met with intense pushback, right?
Yes, massive pushback from major medical societies and clinical researchers. They argue the FDA's blanket warning ignores a highly successful counter-narrative found in clinical trials.
Right. The societies argue that the FDA unfairly lumped controversial, purely cosmetic procedures, marketed loosely as vaginal rejuvenation, with legitimate, crucial medical treatments.
Exactly. For example, a breast cancer survivor experiencing severe menopausal symptoms often cannot take hormone replacement therapy. Topical estrogen could be life-threatening for her.
So for those specific women, these laser treatments might be the absolute only lifeline available to regain a pain-free life and restore basic bodily function. We are just reporting what's in the sources here, but it's a huge debate.
And the clinical trials strongly support that lifeline. The Velavite trial, for instance, was a landmark randomized clinical trial comparing CO2 laser therapy directly against topical vaginal estrogen. At the 6-month mark, the laser showed comparable efficacy to the gold standard estrogen therapy in relieving the symptoms of GSM.
And other randomized controlled trials in our stack echo this, showing measurable improvements in vaginal health indices.
Yeah. Researchers also point out that context matters when looking at the FDA's MIUD database. While those adverse events, like the transverse septum, are horrific, they are statistically incredibly rare when weighed against the hundreds of thousands of procedures performed globally.
So the medical societies argue the safety profile is actually favorable when the devices are wielded by trained professionals treating specific, diagnosed medical conditions.
Right. Not off-label in a cosmetic spa.
Yeah.
If we connect this to the bigger picture, the root of the controversy is a complete lack of standardization.
How so?
The literature review in our sources points out a staggering disparity in treatment protocols across the industry. For the exact same condition, using the exact same device, one clinic might prescribe a single session, while another demands 5 sessions spread over 5 months.
Wow, that's a huge difference.
And the power settings vary wildly. The dwell times how long the laser sits on one spot vary. Without universally agreed upon, standardized guidelines, establishing a definitive safety profile is almost impossible. That lack of clinical consensus is precisely why the FDA felt compelled to step in and halt the momentum.
Okay, so we have a classic clash between regulatory caution based on severe, rare adverse events and clinical optimism driven by positive short-term trial data. But the field isn't just sitting in gridlock, right?
No, definitely not.
Acknowledging the FDA's valid safety concerns and recognizing the dangerous physical limitations of a mass-produced plastic cylinder, medical engineers are actively researching ways to adapt the treatment to the patient's unique geometry.
We are seeing incredible innovations designed specifically to overcome the spatial geometry problem of the vaginal cuff and irregular anatomy. The customization detailed in these sources represents the true future of this technology.
Like the brachytherapy study.
Yes. There is a fascinating study on vaginal vault brachytherapy, which is a procedure that delivers radiation directly to the vaginal cuff to treat cancer. They ran into the exact same problem. Standard radiation cylinders were delivering dangerously uneven radiation doses to irregular post-surgical vaginal vaults.
What did they do?
They abandoned the standard cylinders. Instead, they took detailed CT imaging to map the patient's unique internal three-dimensional anatomy. Then, they used stereolithography, a highly precise form of 3D printing, to create bespoke, custom-fit molds unique to that single patient.
And the results?
The dosimetric results were remarkable. These custom, anatomically matched applicators provided vastly superior, perfectly even energy distribution compared to the standard cylinders. By perfectly hugging the irregular contours, the peaks, and the valleys of the modified cuff, they completely eliminated the dangerous gaps and the high-risk pressure points.
So it proves that we have the technology to completely eliminate the anatomical mismatch. We do not have to rely on rigid wands.
Exact.
Here's where it gets really interesting, because fixing the shape of the probe is only half the battle. The other half is controlling how the laser actually travels through the tissue to prevent those severe surface burns.
Right, the optical side of things.
The sources detail the use of OCAs, or optical clearing agents, specifically using 100% glycerol applied directly to the vaginal wall before firing the laser.
This dives into cutting-edge biophysics. When you fire a laser at biological tissue, the light immediately scatters. Tissue is a chaotic mix of water, proteins, and cellular structures, all of which bend and reflect light differently.
Makes sense.
Because the light scatters near the surface, the penetration depth is severely limited, forcing the delicate surface tissue to absorb massive amounts of heat.
It's like shining a flashlight into a dense fog. The water droplets in the fog scatter the light instantly, creating a blinding white wall right in front of you, and the light barely reaches 10 feet ahead.
Exactly. So glycerol acts as an optical clearing agent because it fundamentally changes the refractive index of the tissue.
Oh.
By applying glycerol to the tissue, it temporarily draws out the water and replaces it within the cellular matrix.
Okay.
Because glycerol has a refractive index that closely matches the proteins and lipids in the tissue, it creates optical homogeneity. The chaotic scattering stops. The researchers increased the optical transmission of the laser through the vaginal wall by an astounding 61%.
Wait, so by just applying a simple compound like glycerol, the tissue temporarily becomes semi-transparent to the laser, completely protecting the surface.
It does. It completely bypasses the sensitive surface epithelium, protecting it from thermal damage, and deposits its energy 3 millimeters deep directly into the endopelvic fascia.
Which is the deeper structural support layer they actually want to stimulate and remodel anyway.
Exactly. It is an incredibly elegant solution. Innovations like the 3D printed custom applicators and the use of glycerol as an optical clearing agent directly address the exact safety issues the FDA is warning against.
Because they remove the blind or rigid aspects of the current tech.
Right. They eliminate the risk of superficial thermal burns and allow for deep transformative tissue remodeling without surface destruction.
This raises an important question, though. The biophysics are sound, the proof of concept is published in the literature, but how quickly can these bespoke, highly protective innovations actually become standard clinical practice?
That's the million-dollar question.
Yeah.
The chasm between a successful lab study and an FDA-cleared, widely adopted protocol in every local gynecology clinic is often measured in decades. Navigating that chasm is the current reality for both patients and clinicians. They are operating in this controversial middle ground, weighing the immediate, profound benefits of tissue regeneration against the mechanical risks of the tools currently at their disposal.
Let's pull all these complex threads together for the listener. We started by exploring how energy-based devices use targeted thermal stress to hijack the body's wound healing cascade, triggering new collagen and restoring blood flow to reverse the devastating symptoms of vaginal atrophy.
But that biological miracle is currently bottlenecked by a mechanical nightmare.
Right. Standard, mass-produced rigid probes are profoundly ill-equipped to safely interface with complex, altered human anatomy, particularly the sutured, irregular landscape of a modified vaginal cuff.
And that spatial mismatch creates chaotic energy delivery, severe burns, and the risk of catastrophic injuries like cuff dehiscence.
Which perfectly explains the intense regulatory standoff. The FDA threw up a massive stop sign based on rare but horrific adverse events, while clinical trials and medical societies desperately defend the life-changing efficacy for women who have no hormonal alternatives.
Yeah, and we are seeing the frontiers of science stepping in to bridge that gap, using CT scans to 3D print bespoke applicators and using glycerol to literally manipulate the biophysics of human tissue, making it transparent to lasers to prevent surface burns.
It all comes back to a single vital goal: improving a patient's quality of life safely.
It highlights how modern medicine is a constantly evolving dialogue between what we want to achieve and the physical limitations of how we achieve it.
Which leaves us with a final thought to mull over today. Think back to that X-ray at the beginning. We love the comfort of a universal, clean, mechanical fix for the human body. But if we are entering an era where we can digitally map a patient's internal topography, physically print a bespoke surgical tool customized down to the millimeter, and then use chemical agents to alter how light behaves inside their specific cells, are we finally approaching the death of the one-size-fits-all medical device? Perhaps the near future of internal medicine won't rely on mass-produced generic tools pulled from sterile plastic wrappers, but on intricate, perfect-fit devices printed uniquely for your body, on demand, right in the doctor's office.